Hello, everyone. My name is Dr. Russell Barkley, and I'm a clinical professor of psychiatry at the Virginia Commonwealth University School of Medicine here in Richmond, Virginia, in the United States. In this lecture, I'm going to speak to you about the various life course outcomes and adversities associated with child and adult ADHD. Where time permits, I'm also going to speak about some of the implications these findings have for how we need to reconceptualize our treatment of ADHD across the lifespan. So let's begin. To start with, I want to forewarn viewers that we are going to be discussing group averages in this presentation, such as the mean differences between ADHD groups and typical or control groups. Or I'll be talking about percentages of people with ADHD. I say this because I don't want you to think that everyone with ADHD is always going to experience all of these adverse outcomes as they grow up with this disorder. All we're showing here is that they are more likely than typical people to experience these various adverse outcomes in life. Many will not have them at all. Others will experience a wide variety of problems. For instance, over 90% of children with ADHD struggle in school and have difficulties with academic performance, among other problems, in that situation. On the other hand, only about 15 to 20% of people with ADHD might develop a personality disorder as a result of growing up with unmanaged ADHD and other factors that I might have time to talk about here. So you can see there's a huge variation in risk. All we're saying is that if you have ADHD, that person may be more likely than someone without ADHD in order to experience that outcome. So keep that in mind, because otherwise I've found that this can be a rather depressing presentation as you look across the wide array of major life activities on which ADHD potentially may increase risk for those negative outcomes. Okay, let's begin then. We're going to start in childhood with one of the earliest appearing risks, and those are the risks that ADHD poses to various aspects of development. In this case, delayed motor development. This makes sense because, as I've explained in other lectures, ADHD is largely, though not entirely, a disorder of the brain's executive system, which is the frontal lobe, which is also known as the motor brain. And therefore, if ADHD comes mainly from that part of the brain and maldevelopment in it, makes sense that there would be motor coordination problems in many people with the disorder. But again, not all. As you see here, about half or more of ADHD children, in some studies less, in others more, but about half of them can be diagnosed with developmental coordination disorder. Others may have delays in their movement skills or just the timing and agility of their motor movements relative to their peers. And this may even continue on into adolescence, where some people may show as much as a 5-year lag in the development of their motor abilities. Other studies suggest that people with ADHD may have more left-sided incoordination than right-sided, although that's not been well established in enough studies to make that a definitive conclusion. A few studies suggested that people with ADHD had mixed dominance, particularly mixed footedness, that is to say that they preferred one foot over the other, as people tend to do, but not as often as other people, tending to use both feet in tests of their motor dominance. Certainly many studies have documented the reduced physical fitness, the reduced strength and stamina, and the increased risk for obesity that we see in children with ADHD over time. Girls may be as affected as boys in having these developmental risks for motor development. And when we compare them to their unaffected siblings, who may have similar motor problems, even if they aren't diagnosed with ADHD. So, motor problems remain a familial risk factor, even if the person doesn't have full ADHD that meets all our diagnostic criteria. And that's because recent studies suggest that ADHD shares certain risk genes with motor development. So it's no surprise that if you have one disorder and its risk genes, other disorders linked to those same genes may appear as well. And we see that here in the area of motor coordination and development. And a few studies suggested that ADHD children are not only more restless with their hands or their feet or in their seat movements and being more fidgety, but they also may show more postural sway, as I'm doing now, forward and back or sideways and so on, as they develop. And again, this makes some sense when we understand that the cerebellum is involved in motor posture and sway, and the cerebellum is involved in ADHD as well. Besides motor development, language problems have been well documented in children growing up with ADHD. Upwards of 50% or more may have problems with expressive language, particularly the motor aspects of language, showing not only excessive talking, but reduced fluency, articulation, maybe an oral apraxia, and the speech that they generate may be less coherent and organized, less logical, and kind of more a sign of mind wandering, if you will, going from topic to topic, and less goal directedness in their language expression. About 60% may show what are called pragmatic deficits in language, which has to do with, again, how well we organize our language in order to accomplish the goals that we have at hand. Some studies show that there's a delay in the internalization of language, which we know across childhood gives rise to what lay people call the mind's voice, or internal self-speech. Children with ADHD talk out loud longer during development, while other children are beginning to inhibit their facial muscles and their oral musculature and begin to use more internally generated language in their mind. Lastly, in the language problems, there is a marked reduction in the ability of language and rules to guide behavior over time toward goals. Parents see this in increased problems with compliance with commands and directions, poor follow-through on assignments that children are given at home or in school, and in other situations, excuse me, where we expect language to serve as a rule and that rule should be guiding behavior rather than what is happening around the individual being more influential in what they are choosing to do. There's a small negative relationship of ADHD with general intelligence. It's not very large, a correlation of about 0.3 to 0.35, which suggests that about 9% of the variation in intelligence is also shared with the variation in severity of ADHD. Overall, ADHD seems to reduce a child's intelligence, on average, by about 7 to maybe 10 points. Not a very dramatic reduction, but enough to be noticeable in research studies that compare large groups of children with ADHD with typical children. Now, some of that adverse effect of ADHD on intelligence is because ADHD is a disorder of executive functioning, not just attention. And executive functioning is needed during the performance of certain, if not many, subtests on general intelligence tests. So it would make sense that the performance might be impaired on an IQ test as a result of these executive function problems, particularly with working memory, for instance, as well as motivation, and not just with attention. But even controlling for executive functioning, children with ADHD still show a small difference in their intelligence from typical children. Again, minor, it would take large samples to detect the difference. Recent studies have explained why this overlap might occur. As I said earlier, the genes for ADHD that are risk genes for the disorder have also been found to be risk genes for lower levels of intelligence. So genes have multiple functions, and we see here that genes can have multiple effects on psychological development. And ADHD risk genes, being different variants than typical genes, may have an adverse effect on intellectual development. There are a number of studies that show that ADHD delays the development of not just self-regulation, but self-care, adaptive functioning, the ability to dress oneself, bathe oneself, be trusted to follow rules in the home and in the community, to essentially look after themselves and care for themselves. This sort of adaptive functioning has been found to be quite delayed in children with ADHD. Now, while some of that is due to their oppositional behavior and perhaps refusal to obey certain instructions or commands with regard to self-care, the rest of it really has to do with ADHD being a disorder of self-regulation. And if that's delayed, then it makes sense that self-sufficiency and self-care may also be impaired as well. In some studies, by as much as 1 to 2 standard deviations difference between an ADHD child's intelligence and their level of adaptive functioning on adaptive behavior inventories. We also find that there might be some cognitive biases linked with ADHD. One in particular that has been replicated several times is that children and even adults with ADHD may show a positive illusory bias, which is to say that they see themselves as functioning in certain domains of life, as well as other people are doing, when in fact they're quite deficient in their performance in that domain. For instance, an ADHD child might tell you that they're doing pretty well in school, perhaps as well as other children. Or they might tell you that they have a lot of friends, at least as many as other children do. But when we go out and we examine their school performance or their peer relationships, that's not true. They don't have as many friends. They're not doing as well in school. We've even seen this in adults, for instance, when we ask them how they think they drive a motor vehicle. Adults with ADHD report that they drive about as well as other people do. But they don't. All of our research, as I will explain later, shows that they are seriously impaired at all levels of driving, including their risk for accident citations and license suspensions and revocations. So there is a disparity in the individual's self-awareness between how they think they're behaving or performing and how they actually are. Now, it's very possible that some of these reports of a positive bias are what we call ego protective, meaning the person is simply saying them because they don't want to admit that they're struggling with performing in certain domains. They realize that they are and that they're not as good as other people, but they don't want to tell that to the examiner or the interviewer. And that's very possible as well. But other studies suggest that ADHD does have a detrimental effect on self-awareness, and that people with ADHD are just not as aware of how disruptive their behavior is, how poorly they're doing in a social interaction, maybe how deficient they are in their school performance. So it's probably a little bit of both. Limited self-awareness combined with perhaps a natural unwillingness to admit to certain problems. Now, I've already said that school is a major area of impairment for ADHD children, and I don't want to go through all of these in detail because they've been documented for decades in our research going back to the 50s and 1960s even in our studies of ADHD, or what then was called hyperactive children. Suffice to say that school is one of the most impaired areas of functioning for children with ADHD. And adults with ADHD recall that to be the case as well. They have more problems across more areas of schooling and academic performance and getting along with their classmates than we see in other children, even other children with other disorders. So there's less attention, less productivity involved in work. Their accuracy is somewhat lower, but it's their productivity that's really the problem. They manifest more disruptive, hyperactive, impulsive, and inattentive behavior, and thus have great difficulties and often experience disciplinary actions within the classroom from the teacher. And this can also lead to increasingly poor relationships with other students at school. Some studies even suggest that if typical children sit next to an ADHD child, their own work productivity suffers as a result of the child's disruptive behavior. So there's kind of a spillover effect into the classroom of the ADHD child adversely affecting other children's academic performance, or at least attention to their work, than we would see in classrooms where there are no ADHD children. Many, many studies document that by the time ADHD children have left elementary school, they are quite behind in their academic achievement skills, being on average about two-thirds to fully a full standard deviation behind in reading, reading comprehension, math, spelling, or even academic subjects like history and mathematics, and so on. So there is a growing adverse effect of ADHD on academic achievement over time. This is certainly understandable when we see that the symptoms of ADHD make a child less available to learn from their environment because they're so distracted by other things that don't involve the lesson plan, and they're interacting with others around them when they should be studying or getting their desk work done, and so on. So we can see that being unavailable to learn eventually has a cumulative effect on a child's academic achievement and knowledge over the first few grades, if not more, of elementary school. Besides this growing delay in achievement, up to half of ADHD children, in some studies even more, have specific learning disabilities. That is, a marked delay in reading, math, spelling, handwriting, and language. They're prone to all of these, the most common, of course, being a reading problem and a handwriting problem. But they're at greater risk for having any or all of them. So over time, the child with ADHD is going to need additional academic support, not just for their ADHD, which is not really causing these problems with reading, math, and spelling, but also with a specific learning disability. Now, that said, some of the symptoms and the executive function deficits that are part of ADHD will lead to certain academic problems, directly causing them. And one of those, besides handwriting, is reading comprehension. ADHD interferes with working memory, the ability to hold information in mind that you're using to perform that task. And certainly, working memory is needed when one reads lengthy paragraphs and must hold in mind the content of what they are reading. And people with ADHD can't do that as well. So we will see a problem with comprehension, not just of what they read, but also of what they watch, such as educational videos, and of what they hear, such as classroom stories or teacher lectures. We can expect all of them, to some degree, to be adversely affected by a child's ADHD. So expect to see growing problems with comprehension of material as the child gets older and as the volume of information to be processed and comprehended is increasing with each passing grade. Looking over at the families of children with ADHD, we see lots of difficulties in their family relationships. I studied this years ago, back in the 1970s and 80s, as did my colleague Charles Cunningham with me, and we published a number of studies. It has since been very, very well examined by other researchers over the ensuing 40 years. In general, what we see is an increased rate of parent-child conflict, lots of extra parental commands, as well as heightened expressed emotion, often hostility between parent and child, a reduced responsiveness of the parent to the child's interactions, as well as the child not being as responsive to the parent's interactions as well. There's often a pattern of more inconsistent discipline in these families, vacillating from lax discipline to harsh and back again. And where that is seen, it is a breeding ground for oppositional defiant behavior that can lead eventually to oppositional defiant disorder. Parents of ADHD children often report a very low sense of self-esteem and confidence in their role as parents. They report more stress, more depression, and more adverse health complaints than do children and other parents where the children don't have ADHD. This is primarily related to the problem with emotional self-regulation that goes along with the executive function deficits seen in people with ADHD. And I'll refer you over to my other lectures on the role of executive functioning in ADHD. So it's no surprise, given all of this conflict and the possibility that the parents have ADHD themselves, which can only make family relations worse, that eventually we would see higher divorce rates among parents of ADHD children, and perhaps earlier divorces as well, even if the rate of divorce may not always be quite so high. We also find that parents have to take more time off of work, participating in work less, and maybe suffering a reduction in their income because of this in order to take care of this very dysregulated ADHD child. We can look at this graphically and understand it better as follows. Here we have parents who now have a new child born into their family. As this child grows up, they're going to become more active, distractible, inattentive, and maybe a little impulsive, particularly if they're a boy. And that's rather natural. So what we see then is that the child's behavior feeds back to have some impact on how the parents are going to react to them. It's a two-way street. It's reciprocal or bidirectional, so that children have as much impact on their parents' behavior toward them as parents have in determining the child's own behavior. It goes back and forth. Now, what happens if this child is excessively active, disruptive, dysregulated, inattentive, and impulsive? They have ADHD. What does that do? Well, they're going to generate a lot more behavior toward their parents, particularly dysregulated behavior and upset and frustration and other signs of emotional impulsiveness and dysregulation. A natural parenting response to that is to increase your efforts at control, more commands, more directions, more shouting and yelling, even more discipline. All of this being done in an effort to get control over the child's behavior. But the child's misbehavior is not due to parenting, and therefore trying to enhance this sort of authoritative or authoritarian parenting isn't going to quell the ADHD and its disruptive behavior. Now, what happens if the parent has ADHD? Well, like the child with ADHD, they're going to be emitting a lot more behavior toward their own children, including unregulated, disruptive, and emotional behavior. What is that going to do? It's going to lead to that inconsistent parenting and that vacillation of lax to harsh parenting, such that the child now is at risk of developing oppositional disorder as well. Explaining why ODD often develops within 2 to 3 years after the onset of ADHD, and particularly in families where one or both parents also have ADHD. And that's going to lead to further conflict, as the child now emits not only ADHD disruptive behavior, but defiance, conflict, anger, and so on that are part of ODD. So you can see over weeks, months, and even years, these patterns of conflict become greater and greater, become well established, and lead to lots of alterations within these families. Particularly, for instance, a reduction in the amount of time spent in leisure activities with the child. So it's quite a tornado or hurricane, if you will, going on in the family with regard to these interaction patterns. But never forget, it's a two-way street. And the child's ADHD is driving a lot of the disruptive behavior and conflict. But if the parent has ADHD, that also will contribute further to the amount of conflict within families. And you can see here how parental ADHD impacts parenting. I don't need to go through this in detail. We've talked already about these effects on monitoring, on consistency of disciplining, and so on. But just understand that to the extent that the parent has ADHD, it's going to interfere with our ability to do behavioral parent training with such a parent until the parent's ADHD has been appropriately treated, at which point they hopefully have become more receptive to such parent training and more likely to adopt and generalize the techniques they're being taught to use in their families on a daily basis. Peer relationships have been extensively studied in children with ADHD, and overall the research shows that at least half of ADHD children have seriously impaired relationships with other children to the extent that they have no close friends. Even if they tell you they do, when researchers have studied the friendship patterns of these children, they're not as positive as the children reported. If the child develops oppositional disorder and, heaven forbid, conduct disorder or antisocial behavior, then that increases markedly the likelihood that they will have impaired friendships or no friendships at all during their first 3 or 4 years in school. And you can see here the types of problems that ADHD children are having in their specific social behavior. Less competent and more clumsy group entries into peer groups, less sharing, promise keeping, turn taking, cooperation, and rule following, being more directive with others, more blunt, more verbally impulsive, emotional, angry, aggressive, and so on. All of these conspire to lead to other children rejecting the ADHD child as a playmate, and thus leading to these longer-term problems I've mentioned in forming friendships with more typical children. And as you see here, some of the social deficits are clearly related to comorbid oppositional and conduct disorder. Others are the result of the executive functioning deficits, such as those in working memory, or WM, as you see here, but especially with emotion regulation. Dysregulated emotion, or poor emotional self-control, has been shown to be the best predictor of friendships across the lifespan. And since ADHD leads to more problems with emotion regulation, again, we can understand why it would lead to problems in getting along with other children. Some studies do show that ADHD children are more likely to be the victims of bullying by other children, particularly if they're smaller and younger than their classmates. But some of it is also due to the child's disruptive behavior, which draws attention to them and makes other children more likely to try and provoke further disruptive behavior from them, and even bullying them. Some studies suggest that if the child has been bullied, they are also more likely to become bullies toward other children, playing both the role of victim and of bully, depending upon the circumstance and the children that they're interacting with. So expect clinically to hear reports of both of those problems, and not just the child being a victim of bullying. Later on in life, particularly by late adolescence and young adulthood, we also see an increased likelihood that the child will be the victim of aggression by other people toward them. And if this child, by adolescence, has developed conduct disorder, they may also be people who indeed perform aggressive acts toward other people as well, including carrying weapons, starting fights, reacting aggressively toward other people when provoked, and so on. So again, it goes both ways, with ADHD predisposing to aggression, but also predisposing to being the victim of aggression from others. Now that's childhood. By adolescence, studies such as those you see here by Hinshaw and Lee and Owens and others have shown that problems with adjustment continue well into the adolescent years, both of boys and of girls. Indeed, their study is one of the largest study of girls followed to adolescence and adulthood that we've seen published to date. And as you can see here, boys and girls remain much more symptomatic, more impaired, more likely to have other disorders like ODD, CD, and depression, more likely to be rated as having social skills problems and deviant peer relationships, and again, more likely to be struggling with academic achievement. So boys and girls with ADHD experience these problems to a greater degree than they do when compared to others of the same sex, as you see next to each line on this slide. But nonetheless, we find that there are a few differences where boys and girls might be more likely or less likely to experience these problems than we see in the opposite sex. Take a look at social skills, for instance, where we see that over 80% of girls with ADHD are rated as problematic in that domain, whereas that figure falls to about 69% of ADHD boys have problems in that domain. This tells us that ADHD in a girl might be leading to somewhat different patterns of impairment and even of comorbidity with other disorders than we would see in boys growing up with the disorder. But overall, both sexes of ADHD children have more problems in all of these domains than do typical children of the same sex. Now, I want to take just a moment as an aside here and explain a study that I've done to you, because in subsequent slides, I'm going to be using the results of this study in the context of the results of other research in that domain. And I thought you might want to know how our study was done. This is called the Milwaukee Longitudinal Study, and it involved my colleagues and I, starting back in 1978, evaluating 158 children with ADHD in Milwaukee at the Children's Hospital. And these children at the time were called hyperactive because that was the diagnostic term. We didn't have ADHD until the 1980s as the term for this disorder. And we selected these children for being highly ADHD in their symptoms, as well as being impaired and as having developed their symptoms by 6 years of age or earlier. We ruled out children who had other neurodevelopmental, neurological, and physical problems. And you can see that we also followed a group of typical children, selected as coming from the same schools and neighborhoods, as did the children with ADHD. And we followed these children for many years, evaluating them about every 5 years up to about age 27 to 32. At that last follow-up, we then divided the ADHD children into those whose ADHD had persisted, which we label here as H plus ADHD, meaning hyperactive as a child and ADHD by adulthood. We also had the ADHD children who did not meet all criteria for ADHD by adulthood, and that's the H minus group. They were hyperactive or ADHD in childhood, but no longer met all the criteria in adulthood. By the way, many of them did not outgrow their symptoms. They just lost enough symptoms not to meet all of the diagnostic criteria. And then, of course, we have our control group of children. I'd just like to give a shout out, if you will, but acknowledge the collaborators I had on this long-term 20 to 25 year follow-up study, and you see them here. My thanks to all of them. Now, I know you're going to ask, how much treatment did these children receive? Well, they didn't get treatment through the project itself, but we certainly documented how much treatment they were getting in the community as we reevaluated them at age 15, then later at 21, then later at a mean age of 27. Here you see that many of the children were receiving ADHD medications in childhood, 80% in fact, for an average of about 3 years. Many had received individual therapy, family therapy, and although you don't see it here, special educational services as well. By age 21, notice there's a marked decline in treatment participation. Now only 28% of them continued on medication through high school, and only 13% continued on it after leaving school, up to age 21. And you can see a decline in the types of psychological therapies that they were receiving as well. So notice that over time, as ADHD children grow up, they participate less and less in therapy as they become more independent of their families. And by age 27, sorry to report that only about 10% of them were receiving any form of psychiatric medication for management of their ADHD or any other disorder for that matter. And only a small minority were participating in any kind of outpatient or other form of therapy. So basically, the sample of children that I followed is principally a childhood treated sample that is then discontinuing treatment over time, such that by adulthood, most of them are no longer in treatment. Indeed, during high school, most of them are no longer receiving treatment. That's going to help you to understand some of the findings later on, because overall, regardless of what domain we studied in their outcome, treatment had no significant effects on any domain. And that's because they didn't continue. The treatments they received were effective at managing them at that time. But once you stop the medication, just like someone with diabetes stopping their insulin, you're going to go back to having unmanaged ADHD. And therefore, we're not going to be able to detect any effective treatment on their outcome. And by the way, it's not just my study, pardon me, that found that. All follow-up studies have found virtually the same thing. Treatment in childhood, if not continued into adolescence and adulthood, has no detectable or significant impact on altering the adult life course of these individuals. The upshot of all of that is we need to make sure that treatment continues as much as possible during those critical adolescent years and, if needed, into the adult years. Now, one of the first questions people ask from such studies is how persistent is ADHD over time? Well, it depends on when the studies were done and what criteria were available for diagnosing ADHD. The studies that were done in the 1970s and 80s didn't have DSM criteria to use, so they had to develop their own criteria, as I did in my longitudinal study, using rating scales and interviews of the hyperactive, impulsive, and inattentive symptoms known to be part of the disorder, even if we didn't have official DSM criteria. Now, that can introduce a little bit of variation and sloppiness in diagnosis. And as a result, we found that studies that were done back in the 60s and 70s up through the 80s often found a rate of persistence from childhood to adolescence of about 50%, suggesting that either the remainder no longer had the disorder or no longer qualified for the criteria in use in that study. But as we get better criteria, more rigorous diagnostic criteria, and a consensus as to how to diagnose ADHD, which was achieved by using the DSM manuals, then we see that with increasing rigor of diagnosis, we have increasing persistence of disorder being detected from childhood into adolescence. In my Milwaukee study, it was nearly 80% of the children continued to be highly symptomatic and impaired, and to meet the new DSM criteria for ADD or ADHD, as it would come to be called later on. By young adulthood, the results of these studies are quite mixed, and we'll see that that has to do with two factors. One, who are you interviewing about the disorder? You see, by adulthood, many studies stopped interviewing the parents and teachers and instead only interviewed the patient who grew up with the disorder. And while that might make sense, who better to know how you're functioning in adulthood than you? As I already told you, people with ADHD have very limited self-awareness and appreciation for their problems. And that's exactly what we found in our study. Notice that when we interviewed the children based on the DSM criteria, only about 3 to 8% of children in these research studies, my own included, reported enough symptoms to get a DSM diagnosis, making it look as if almost no one has a disorder that persists into adulthood, if you used their report. But if you interviewed their parents, as we did in that study, you found that the rate of persistence was 10 times higher. Now, nearly 50% of the parents of these children reported that the young adult still had enough symptoms to meet the DSM criteria. So there's a marked difference in the persistence and the presence of a disorder in adulthood based on who you interview. And that is one reason, among many, why in the recent DSM-5 version of our diagnostic criteria, a new criterion was added, a new requirement. You must corroborate what patients tell you through the reports of others, and if they're not available, through other sources, such as archival records, educational, school records being among the most available. And that's to be sure that you're not overlooking the disorder by relying solely on self-report. This fails to address a second problem that occurred in these follow-up studies, and that is that the DSM was designed mainly for use with children when it was first invented. Its symptoms and their wording, and the threshold for how many symptoms you have to have are based on children, not on adults. And therefore, it's possible that with a developmental disorder like ADHD, which does tend to decline somewhat with age, people can outgrow the DSM, but not be outgrowing their disorder, because the DSM doesn't contain more appropriate symptoms of what ADHD looks like in adolescence, and especially in adulthood. As an example of that, we now know that hyperactivity is primarily a young childhood symptom of ADHD, and that it declines markedly with age, and by adulthood is of no diagnostic value whatsoever. But if you rely on the DSM, which is heavily weighted with hyperactive symptoms, 6 in fact, then it would appear that you're outgrowing the disorder as your hyperactivity declines, when in fact you're just outgrowing these DSM criteria and their childhood emphasis. So what to do then in a follow-up study? Well, we shifted to using what is called a developmental approach to diagnosis. We kept comparing the people with ADHD to the typical control group or the population, if we had norms for the population, and we continued to say, if you are in the top 2 to 3% of people of your age in your symptoms, in other words, if you're above the 97th to 98th percentile in your symptoms, we're going to consider that to be a diagnosis, regardless of what the DSM requires. And I call this a developmental reference criterion. And notice what we found. Again, if we interviewed the children as adults, about 12% of them fell at that level of deviance. That's more than 3 times the rate of ADHD based on the DSM just above this, as you see on my slide, but still very low. If you interviewed their parents, as we did, and used this new developmental definition of ADHD, notice that the rate of persistence was 66%, not the 46% you see above for the DSM, but another 20%, or to put it another way, nearly 50% more children were identified as having adult ADHD using a developmental reference point than if we had just relied on the DSM and its mainly childhood phrased symptoms. So the difference there between the DSM and the developmental definition shows you the problem with the DSM. It's developmentally insensitive, and thus can lead to people outgrowing the DSM, even though they are not outgrowing their disorder when we compare them to other people of their age. And look down toward the bottom. What if we define disorder as continuing to be functionally impaired more than typical people? The rate of persistence would be 85 to 90%, even if they didn't meet the developmental definition, which is a very strict definition, by the way. Clinicians don't use the 98th percentile. They tend to use the 93rd percentile as a demarcation of someone's developmental inappropriateness or deviance, say, on a rating scale of ADHD symptoms. We were using the 98th percentile. So our figures would be even higher if we use what clinicians used. So it's just safe to say that somewhere between 66 and 90% of children with ADHD will be symptomatic and impaired in adulthood, even if they don't meet the DSM criteria. And to me, that's evidence of persistence of disorder, suggesting that ADHD is a vastly more persistent disorder than earlier follow-up studies, particularly based on DSM criteria, and especially when all they interviewed was the patient themselves. would have yielded. Now, what happens at age 27? Well, there does continue, as you see here, to be declines in the overall level of symptoms. And here we've defined ADHD by three different means. The dark blue line are people who met all the DSM criteria. We'll call that the syndromal definition or DSM definition. The next two lines, the light blue and the yellow, are the developmental definitions. The individual continued to be symptomatic at the 93rd percentile, 1.5 standard deviations, which is in yellow, or at the 98th percentile, 2 standard deviations above the mean, which is the light blue. The gap between these definitions, developmental here, DSM down here, is the problem I just mentioned with the DSM being developmentally insensitive to continuing symptoms and impairment. But we can also see that there is a growing number of individuals who no longer met criteria for ADHD, and in fact, some of whom may well have recovered from it and have become normal. And here are those figures if you want the numbers. And you can see that about 35 to 46% of children with ADHD could be said to have been normalized based on parent reports. However, when we also added that they had to be normalized by both self and parent reports, the rate of recovery was just 14%. So, to summarize, it depends on how loose or generous you want to be in defining recovery. If you define recovery based only on one person's report, it's a relatively high figure. About 35% are no longer impaired and symptomatic. On the other hand, if you base it on both reports, that figure falls substantially by more than 15%, or 50% rather, down to a level of about 14% could truly be said to have become normalized or recovered by adulthood. Now here we see the pattern for self-reports. Remember the earlier graph here is based on parent, but here's the self-report. It's the opposite pattern, isn't it? Where we see more and more of our study participants are reporting symptoms of having the disorder, and less are reporting recovery from the disorder. Why is that? Well, as the frontal lobes continue to mature, as self-awareness therefore continues to improve, as children move away from home and encounter many other people and situations that give them feedback about themselves and their functioning, all of that conspires to result in people with ADHD waking up and, as we say here, smelling the coffee and realizing, gee, maybe I really do have these problems that my parents talked about when I was a child. By the way, these patterns, although they're opposite, are converging on a common point, converging on people with ADHD as children by adulthood beginning to agree more and more with their parents' reports about how they are currently functioning. So that by age 27 to 32, the reports of these young adults now are becoming somewhat more reliable, trustworthy if you wish to think of it that way, and in agreement with the reports of other people. But not until then. Now, could we find anything that predicted who persisted with their disorder and who didn't? And did any other studies find any such thing? Not really. Research shows a few predictors are related to outcome, but they're not very good at predicting. That is to say, they don't account for a great deal of the variation in the persistence of the disorder into adulthood. And the ones that we did find, weak as they were, make sense. How severe was your ADHD the last time we evaluated you? The more severe it was, the more likely it continued. Makes perfect sense. How much education did you get through high school and after high school? The less educated you were, the more your disorder persisted. But that makes sense too, because the more severe your disorder, the less education you would have gotten, and severity of disorder would have also predicted persistence. Other people, just like us, such as Joe Biederman's studies, have found that the extent to which children grew up with other disorders besides ADHD was also related to how persistent their ADHD was. That's known as comorbidity. And to the extent that their mothers continued to have psychopathology during childhood also was related to persistence in adulthood. But let's understand something. Both comorbidity and maternal psychopathology are related to the severity of the child's ADHD. More severe children have more comorbid disorders and also have more parents who are likely to also have ADHD, among other problems. So again, it makes a little sense to us that these factors might predict severity of disorder and persistence of disorder at outcome. But in general, the take-home message from these follow-up studies is we haven't found an awful lot of good predictors in the area of psychological and social variables. That still leaves out some hope that there might be predictors in the realm of biology, such as looking at the genetics of ADHD and whether certain variants of these ADHD genes are related to persistence of disorder over time. We certainly know that some neuroimaging findings are predictive of recovery, such as the extent to which the frontal lobes and the executive networks more quickly mature in adolescence would certainly be predictive of whether or not you still have this disorder in adulthood. So in time, we may find that certain neuroimaging and genetic factors could be used to predict life course. We're not quite there yet, but there's some promise of that. Now, I mentioned that education was one of the most impaired domains in childhood in children with ADHD. It's therefore no surprise that by adulthood, all studies have documented a variety of adverse outcomes in the educational histories of people with ADHD. And here are many of them. Now, when you look at the percentages in parentheses, if you see the abbreviation MKE, those are the results of my study at that age 27 follow-up. If you see a range of numbers, like 20 to 40% were retained in grade, that's the range that's been found in all of the other follow-up studies of ADHD children to adulthood. Now notice that many ADHD children, especially in my study, had been retained in grade at least once because of their academic problems. That is to say, they had to repeat a grade. Below that, notice that I've mentioned a study, of which there are several, that show that this is harmful to children, that the very act of retaining them in a grade will lead to new adverse outcomes that would not have been there had they not been retained. And there are ways of statistically demonstrating that in analyzing the results of follow-up studies. But suffice to say here that we should not be recommending grade retention as a solution for ADHD because it creates its own problems. It can lead to loss of interest in learning, loss of motivation to attend school, more aggression in males, more depression in females, greater peer relationships than they already had before they were retained. That is, greater problems with peers. And finally, a much greater likelihood of simply dropping out of school before completing compulsory education than would have been the case had they not been retained. So those are many of the harms we do when we retain children in school, particularly ADHD children, and therefore we don't recommend that as a solution. Now, in the U.S., ADHD children were eligible for special educational services, but mostly after 1991 when we changed our educational laws. Prior to that time, they only got special services if they had some other disorder, like a learning disability or a language disorder, that was warranted and authorized to receive special education. We've noticed since 1991, in more recent follow-up studies, that the amount of special education children receive is now toward the higher end of services, and that's good news. More like 50% are getting help in school than was the case in my study. Even so, studies continue to show that because of behavior problems and disciplinary problems, many children with ADHD, 60% in my study, had been suspended at least once from school because of their behavior or conduct. Certainly this was predicted by how many children had developed conduct disorder by adolescence, but ADHD alone was also a risk factor for suspension. And notice for expulsion, which is being kicked out of school entirely rather than just suspended for a few days or a week. And here you see that 14% of children in my study and 10 to 18% in the other studies were expelled from school and not allowed to return. Now, in the Milwaukee study, we had a very high dropout rate of children not completing high school, about 32%. And you can see that the other studies are very similar to that. But I would like to point out some hopeful news. There have been additional follow-up studies that were started in the 1990s and that are completing their follow-ups now of those children as they reach adulthood. Now keep in mind that many of the children in these new studies did receive special education, weren't likely to be retained or expelled. And what do we find? The dropout rate is very similar to typical children now. In other words, there's a marked reduction in the likelihood of quitting school by providing special educational services to these at-risk children. So that's good news. It means that assistance in school can help with these educational outcomes. But by adulthood, even among the children who completed school, we found that they had lower grade point averages, lower achievement test scores, lower class ranking as a result of their lower grades, and that many were unlikely to enter college. Notice the difference. Over 77% of the children in our control group went on to college, and about 35 to 45% of them completed college. That figure was only 22% of the ADHD children attempted college, and look down below. About 5 to 10% completed it. So this explains why ADHD children have much less educational attainment than do other children upon reaching adulthood. College is difficult for them. They're unlikely to see it through. Hopefully, with the new requirements that colleges must provide accommodations for people with ADHD in the U.S., perhaps we will see improvement in these graduation rates. Now, what should we do about these educational risks? One thing, of course, is to educate teachers and schools about ADHD and its associated academic risks, and encourage them to provide services to these children as soon as these problems occur. A second is to make sure that we've trained teachers in the appropriate strategies, behavior management methods, and other curriculum adjustments that they can use to help ADHD children succeed in school. Perhaps implementing an ADHD representative or liaison at school who has more expertise in ADHD and who can consult to other teachers in advising them on how to manage an ADHD child in their classroom. Maybe that would be helpful. Schools that adopted that kind of liaison model or school consultation model have children with ADHD who do better in school than schools that didn't adopt that system. And by the way, that school liaison can also be meeting with parents when parents call and have concerns, and then can represent those parents' interests by speaking with the child's teachers, where the parent then begins to feel like they've been listened to and their concerns were heard and that action is being taken to help their child. So the liaison can work both ways, helping parents negotiate the system and get information about their children, and consulting with teachers on how to help in the classroom. We have also shown that early screening and identification can also be helpful. At kindergarten, for instance, using simply a rating scale of ADHD symptoms and beginning to pull out children who are being rated very high on those rating scales by their parents, referring those children for a more thorough psychological or psychiatric evaluation, led us to find upwards of 70% or more of children who screened positive for ADHD wound up actually having ADHD in that evaluation. And those who didn't were found to have other developmental disorders, such as learning disorders, high functioning autism, oppositional and conduct problems, and so forth. Some studies indicate that you don't need formal special educational services, as we have in the U.S., such as separate classrooms, with teachers who have had additional training. Instead, what are called pre-referral forms of assistance, having a consultant meet with the regular education teachers and give them a few simple strategies to try in the classroom, could wind up with fewer children needing to go on to these more expensive special classes for children with learning and developmental disabilities. So we refer to this as pre-referral assistance or consultation. If necessary, of course, the children can go on and get the more systematic and formal types of educational assistance that special educational services provide. But it isn't necessary for all children. Research also shows that if you institute medication for ADHD earlier and you use one of the more modern extended release forms of the medication, this too greatly reduces the educational impairments in children with ADHD and can lead many more of them to complete their education than might otherwise have been the case. We'd like to recommend that schools obtain vocational assessments on ADHD children, and to some extent in high school, provide some technical training in some occupational skills before the children leave school, so that if they choose not to go to college, and many of them won't go, they leave high school with some employable entry-level skills to get a job in the workforce. The next domain that we're going to examine, of course, after leaving school is employment. What happens in the workplace when we study children grown up with ADHD or adults with ADHD? We identify many different kinds of problems. Now again, not all adults with ADHD have these problems, but notice that they are at higher risk of doing so than are others who don't have ADHD. So notice, about 55% of ADHD children had been dismissed or fired from a job, compared to only about 23% of control children by age 21. And by the time they got to age 27, another 43% of the ADHD children had been dismissed from employment, versus just 14% of the control group by that age during that interim period. So, people with ADHD are more likely to lose their jobs. They're also more likely to change jobs out of boredom, as you see here, and to skip from one job to another, with ADHD children doing so more than twice as often as the typical control group children did. When we ask employers to rate these employees on levels of ADHD and oppositional symptoms, as well as on their workplace performance. The employers rated them as having many more symptoms than we saw from the employers of our typical children. And as you see on the next slide, their ratings of workplace performance were worse. Other studies, such as the one in New York, indicate that by the time children with ADHD are at least 30 years of age or older, a lot more of them have moved into self-employment than we see in the typical population. Perhaps this is because they have trouble holding a job when they work for other people, and therefore, of necessity, they have to go to work for themselves. Or it may just be that self-employment is a particular niche in which ADHD individuals are more successful and therefore are more likely to thrive and to opt into self-employment as a result. So it's hard to tell why that figure is higher than that of typical people. But it does suggest that self-employment and maybe even entrepreneurial activities might be more suitable to people with ADHD than it is to others. Even so, all studies that have followed children to adulthood show that they earn less money, are more likely to be receiving some type of social or unemployment assistance. They're 12 times more likely, at least in Sweden, to be out on work disability as a result of their ADHD, which is markedly higher than is seen below for conduct disorder, CD, or for learning disorders, LD, and very similar to what is seen for autism spectrum disorder, which is kind of interesting. Makes it look as if ADHD by adulthood might be as impairing in the workplace as is autism spectrum. Now, we also found that these individuals had more health problems, less education, took more time off from work, in other words, had less time in their role as an employee, and as I said earlier, were more likely to leave their employment. Some of this is related to their disadvantaged backgrounds, but most of it was related to their ADHD. So what to do about this? Well, we're not sure because there are no real studies of this other than a few recent ones looking at the impact of medication on those statistics. So what could we do? As with school, make sure that employers are educated about ADHD and the kinds of adjustments and accommodations that could be made for the ADHD adult to be more successful there. We have to be careful of that, however, because some employers will not be very sympathetic to an employee having ADHD and might take steps to document their failures, perhaps more rigorously, and therefore get them fired. But working with some employers might be a good thing to do where those employers are open and compassionate to helping adults with ADHD. I've mentioned what I think is the value of vocational assessment and technical training in high school might help improve these figures as ADHD children leave school with employable skills. We don't know, no one has tried that, but it makes common sense. Counseling the adult with ADHD about what kinds of employment might match their disorder, that is, an ADHD-friendly workplace. And my books on adult ADHD talk about the kinds of employment that seem to be more suitable to people with ADHD and in which they report being less impaired. For instance, moving into athletics or becoming a physical education teacher or joining the military, becoming an emergency medical technician or a policeman or a fireman. All of these are very active occupations in which there's a great deal of movement and in which the individual, particularly in the military, is receiving additional care, structure, discipline beyond what others would get outside the military. And maybe that's helpful too. Extra structure can be helpful to them and extra feedback as is done in the military. And there could be disciplines such as performing arts, musician, comedian, actor or actress. What about self-employment in the trades, carpenter, plumber, landscaper, and so on? Or how about overall construction and construction work? And then, of course, what about the culinary arts and cooking? These are all areas I suggest because they're areas in which we find ADHD adults more likely to be employed and to report that they are more effective in those kinds of employment than are others. So it seems that movement, activity, structure, feedback, change, all of these may play some role in what kinds of jobs are good for people who have ADHD, such as door-to-door sales, for instance, that involves movement, change of scenery, meeting with many other people, conversing with them, and, of course, selling them things. And maybe ADHD people seem better at that, because we certainly find that more people in sales occupations are likely to have ADHD. And then lastly, as I mentioned in school, making reasonable accommodations for their disorder, but also using extended release medications might be beneficial in the workplace just as much as they were in school. And indeed, recent large-scale studies and even meta-analyses of many studies show that when adults with ADHD are on medication, many of these risks are reduced when compared to the months where they are off their medication. And by the way, that includes risk for accidents, injuries, suicide, and early mortality, not just improvement in their workplace or education or driving or peer relationships, all of which have also been found to be improved by medication. Now, of course, when you work, you earn money. So how do people with ADHD handle money? Well, not well. As you can see here from my Milwaukee study, look at the black bar, the one on the left for each category of financial problems. Those are the ADHD children who ADHD persisted into adulthood. The white bar is the group whose ADHD didn't persist, but many of them were still symptomatic. And the other bar on the right, the third bar with the more dense polka dots in it, that's our control group, our community group. And so you can see when we look across these various problems with money, people growing up with ADHD, even if they no longer had the diagnosis, still have problems with overall financial management, with impulsive buying, with missing routine payments on their credit cards, cars, rent, utilities, and other debts. Maybe even having missed making a payment on their card and having exceeded their credit limit. Notice on the far right that overall, by age 27, the higher percentage of adults with ADHD had very poor credit ratings with credit agencies than did more typical individuals. Makes perfect sense when you understand all of these more specific financial problems. Here you're going to see some additional difficulties with financial outcomes as a result of growing up with ADHD. Notice that adults with ADHD earn about 37% less than comparison individuals. 23% of them might be in need of financial assistance, particularly from family members, as young adults. They had lower starting salaries and progressed up the income level in their employment much more slowly than did other people. You can see here that 66% of them had saved little, if any, money, and twice as many had absolutely no money saved up at all in comparison to the young adults who are typical people and don't have ADHD. And again, we've already discussed many of these other specific financial problems. Notice on the last line, however, if we total up across the working life of someone with ADHD and someone who doesn't have ADHD, there's nearly a $1.3 million difference in income during their careers in those with ADHD compared to those in the control group. That is a substantial difference in income when it is accumulated over one's working life. Another area in which people with ADHD have major difficulties is in operation of a motor vehicle and driving on our highways among other drivers. Look at all the problems researchers, including myself, have found in our detailed studies of this domain of ADHD outcomes. More problems handling the vehicle, slower reaction time, much less use of safe driving habits as witnessed by others, much more likely to drive before they're allowed to drive, so driving illegally as young teens, greater risk taking, more illegal actions, more crashes, citations, and certainly a worse number of crashes. That is to say, the crashes they have are markedly worse in terms of dollar damages done and number of people harmed in the accident. So their accidents are worse. All of this leading to nearly 3 times the likelihood that your license would be suspended during the first 10 years of driving than we would have seen in other people. And you can see the percentage suspended here. My studies also show that alcohol, even in low doses, has a very detrimental impact on the driving of these individuals. And that, of course, is sensible. When you look that they're impaired in their driving already, driving as if they're already intoxicated when they're not, even adding a little bit of intoxication into that mix can be very detrimental on their driving performance and their increased likelihood of crashes and possibly even injury and death. Studies out of Brazil and elsewhere show that people with ADHD are more likely to engage in motorcycle sports, other motor sports, and extreme sports, and are more likely to suffer injuries from that participation than we see in typical adults. All right then, what to do? How to help? First, we need to educate families of teenagers about these risks. I find that many people don't. That's a shame. Parents should not feel as if they need to allow their teenager to drive at the same time that other teens are driving if their teen has a diagnosis of ADHD. We need to make sure that primary care physicians are also well informed about these risks and sit down and counsel families about going slow with the learner's permit, maybe adopting a more graduated licensing approach, perhaps also using medication while driving, which I mention on the next slide. Graduated licensing refers to taking a longer period to achieve independent driving than is the case with other individuals. Perhaps spending 3 to 6 months under close supervision with daytime driving. And if they handle that, moving up to nighttime driving for another 3 months with adults in the car. And if they handle that, allowing them to drive alone. And only after 3 months of that, without problem, allowing them to have other peers in the car with them and be fully independent drivers. Even then, research has shown that the availability of smart technology, such as cell phones, in the car increases distractibility and risk of these driving problems by more than 50%. And while it does that for typical teens also, ADHD teens are already at risk because of their ADHD, and multiplying that by 50% just further magnifies these adverse outcomes. Telling ADHD teens not to use their cell phone is no good. That won't work. They're more likely to do so. But finding other ways to do so, such as through applications that are downloaded onto a cell phone, or through purchasing of a Bluetooth transmitter or other device that blocks cell phone signals in the car when the car is turned on, are ways of simply preventing the use of smartphones and therefore eliminating that source of distraction. My friend Dan Cox, working at the University of Virginia, has shown that even something as simple as allowing them to drive cars with manual transmissions reduces some of their risks while driving because they're moving more, participating more in the shifting and the braking and use of the clutch than you would do with a manual transmission. And that involvement in driving may enhance their attention to their driving. Obviously, parents need to supervise the use of vehicles with teenagers who are driving, understanding where they're going, when they're coming back, and even checking up on them unexpectedly to see if they are where they said they were. Using apps like Find My Smartphone or other GPS tracking apps that can be installed on the teen's phone can also allow parents and others to monitor the teen's use of the vehicle and where they're going. You can even, for a few $100s, install a camera called the Drive Cam that goes on the rear view mirror and that records not only what is taking place on the roadway in front of the driver, but also has a second camera that is recording the driver's behavior as well. And parents can look at these videos when the teen gets home to see just how well or poorly the teen was driving. So there's lots of technology and devices we might use to reduce some of these risks. But of all of them, the one that to date has shown the most benefit is taking medication while driving and avoiding alcohol, of course. ADHD medications, particularly the stimulants, have been found to substantially reduce the risks of collisions and traffic problems and speeding tickets among teens and adults with ADHD. Let's move on and talk briefly about comorbidity, although I have a separate lecture on that. Upwards of 80% of children and adults who are referred to clinics for their ADHD have at least one other disorder, and over 50% of them have at least two other disorders. What sorts of disorders are we talking about here? You see them on this graph. At the top are the impulse control disorders that have to do especially with control of impulse, risk of addiction, control of anger and hostility, and generally antisocial behavior. ADHD individuals are at high risk of having those disorders in childhood and adulthood. To the right are the emotional disorders, major depression, dysthymia, and other mood disorders, particularly the new disruptive mood dysregulation disorder. Further down, you see the disorders related to anxiety and OCD, such as tic disorders and many anxiety disorders. ADHD children are at somewhat greater risk of being on the high end of the autism spectrum of disorders, and a small but slightly higher percentage of having intellectual disability. I've already mentioned the very high risk for motor problems and specific learning disabilities that ADHD children have, and that in many cases, though by no means all, will continue into adulthood. Lastly are the personality disorders that you see over on the left, with ADHD leading to especially a risk for antisocial personality, borderline personality, and passive-aggressive personality. Now let's put some numbers beside each of these. Here you see the risk that ADHD children have for each of these disorders as they grow up and move into adulthood. Note below around females with ADHD carrying a very specific risk for binge eating, impulsive eating pathology, and even eventually developing bulimia. Otherwise, these other disorders I've already mentioned. And note that for each of them, ADHD conveys a greater risk than we see in typical individuals. Often 3, 5, or even 8 times more risk than is the base rate for those disorders in the population. One disorder to pay particular attention to is the development of antisocial activities and conduct disorder through adolescence, which is a strong predictor that such antisocial activities will continue into adulthood. And here you see that risk. This again is from my Milwaukee study, and this is what we found in terms of what percentage of our groups had experienced or had committed, that is, any of these antisocial activities. And you can see that across the board, for all types of activities, people with ADHD that persisted were more likely to have engaged in these antisocial activities than those whose ADHD hadn't persisted. But even in the non-persistent group, many of whom are still symptomatic but not diagnosable, they showed a risk for more antisocial activity than our control group. Look over at the far right two bars. Risk for being arrested, risk for going to jail. Those are very high rates when compared to the typical population. And that has been found in all other longitudinal studies. ADHD poses a striking risk for ongoing antisocial behavior that persists into adulthood. My study identified 3 kinds of antisocial activities. So if you took all 13 of those antisocial acts and you factor analyze them to understand their commonalities, you get 3 dimensions. Predatory, which is the use of aggression and weapons against other people, that was mostly related to conduct disorder, not so much ADHD. What we called self-sufficient crime, running away from home, stealing money to support yourself, engaging in prostitution to try to support yourself. That type of crime was also related to conduct disorder. But note at the bottom, there are drug-related criminal offenses, possessing illegal drugs, using them, selling them illegally, stealing them from others, or simply stealing in order to get money for these drugs. This was related to ADHD and not just conduct disorder, though the presence of conduct disorder also had an impact on this risk. What this says is that children growing up with ADHD alone, even if they never develop conduct problems or conduct disorder, are still carrying some risk for substance use and sale and drug-related antisocial activity. ADHD children, as we said, have difficulties making and keeping friends in childhood and adolescence, and that problem continues into adulthood, as we found in our studies of adults, such that even those who go on to be married have lower satisfaction with their marriage, a higher likelihood of having affairs during their marriage, a greater likelihood of divorcing their partners, and an increased probability for violence in their intimate partner cohabiting relationships. Notice as well that these individuals were more likely to have had children as teenagers, so seeing an earlier age of childbearing and having their own children to raise. And we found that being an adult with ADHD markedly increased their parenting stress in managing their own children, even if their own children didn't have ADHD, though some of them certainly did because of the genetic risk posed by the parents' ADHD. In general, when we look at lifestyle, we see a greater propensity for drifting toward using social media, technology, what you would call screen time, even watching television, playing internet video games with others. They're more likely to do that than socialize with other teens. ADHD children and adults seem to have a particular risk for internet gaming addiction. That risk is about 15 to upwards of 22% when we look at studies, particularly studies coming out of Asia. They spend less time engaged in improvement, self-help, adult education, and less time in exercising, all of which suggests that not only are they not going to move further up in their education and employment, they're going to be in less physically healthy or well, and they're also going to have a greater likelihood for obesity. We found that, as did other studies, a greater likelihood of having at least one episode of homelessness before age 40 to 41, and as I reported earlier, substantial problems with managing money and credit. One area that my study was the first to examine, but has now been duplicated by others, is the relationship of ADHD to sexual behavior through adolescence and adulthood. We did not document any increased risk for sexual disorders per se, although other studies of adults do suggest that males with ADHD might be more prone to premature ejaculation and that females might be more prone to pain during sexual intercourse or dysmenorrhea. But generally what we found was simply a heightened pattern of risk-taking behavior, with teens and young adults beginning their sexual careers earlier than others, being more likely to change sexual partners during any fixed period of time, so having more sex partners during the follow-up period, spending less time with each partner, engaging in more casual sex out of committed relationships, using contraception much less than other people, all of which leads to a greater risk for a teen pregnancy, for having those children, and a greater risk of having multiple children, in addition to the greater risk you see here for sexually transmitted disease. So, people with ADHD are likely to bear their young at an earlier age and to be at risk for sexual transmitted diseases more than are typical people followed into adolescence and adulthood, suggesting there is a much greater overall pattern of risky sexual activity going on in this disorder, even in adulthood. Now, what do we do about this? Well, we don't know. I don't know of a single study that has tried to develop psychosocial interventions for this area of risk, other than a few studies recently done using medication management that have documented a much greater reduction in teen pregnancy among teens and young adults who were on medication during their adolescent and young adult years. Hopefully that would continue if they stay on medication, but we don't know. So once again, we fall back on common sense recommendations, educating parents so they know these risks and can supervise their teens and young adults more, educating primary care providers about the risks so that they too can counsel their patients on contraception and on safe sex and so on. Working with other social service agencies that have to deal with ADHD and these teen pregnancies might also be of some benefit. Delaying couples dating, talking to teens about sex and risky sex and use of contraception might also be beneficial. We just don't know. Perhaps recommending the human papillovirus immunization would be a good thing to consider. Why? Because one of the risks for HPV infection is frequency of changing sex partners, that is, how many partners have you had in your life, and use of contraception during sex. And we know that ADHD teens and adults are at greater risk of doing those things, and therefore would be at higher risk of contracting such an infection. And that puts them at a higher risk for cervical, throat, and rectal cancers by mid and late life as a result of that HPV infection. So maybe immunization is one thing to do during late childhood, early adolescence, as these individuals begin their sexual careers. As you can imagine, all of the things that I've just talked about convey a risk for cost to society. And studies now have looked at the excess economic costs of someone with ADHD and have calculated them both on a per year basis as well as on a lifetime basis. Let's take a look at these. Studies indicate that about $1.8 billion is expended in the U.S. for ADHD treatments. Sounds like an awful lot when we consider that. But let's look at the cost that ADHD poses when it's not treated. $12 billion in U.S. healthcare costs, and that's per year. $14 billion in cost of healthcare to the families of those with ADHD because of their increased needs, increased ADHD, and other problems. $3.7 billion in lost work productivity for the adult with ADHD and for their family members if they're raising a child with ADHD. Overall, the difference in costs between an ADHD adult and a sibling who's not affected by the disorder, that's a very important comparison there because it controls for a lot of other possible background and confounding factors. Notice the difference. $20,000 more per year ADHD costs than compared to a sibling who doesn't have the disorder when we look at healthcare costs, disability claims, and state services that the individual requires. Research in Israel shows that ADHD costs nearly $290,000 more per year for all these other things that are risks, the educational risks, the criminal behavior, and antisocial activity, and victim costs, and car accidents, and substance use and abuse. All of them added together come to nearly $300,000 is what society is paying out per year for the costs of unmanaged ADHD. There are other economic costs I don't want to dwell on, but we'll leave you with on this slide and with my handout, and you can see the calculation of costs associated with each of these more specific outcomes, educational outcomes, job status, annual income, and so forth. But as I said, it all conspires together to create a tremendous societal cost or impact of ADHD on our communities, on these families, and on society and our governments more generally. Again, what predicts positive outcomes? Not what predicts ADHD and its persistence, but that someone with ADHD may be functioning relatively well compared to others with the disorder. These are the factors that research shows might pertain to better functioning in adulthood. And by looking down the list, they make imminent sense. So I won't spend any time on them other than to share them with you. In conclusion, ADHD is associated with numerous childhood, adolescent, and adult impairments in virtually every major life activity we have studied to date, including health and wellness and medical problems and early mortality, none of which I covered in this lecture because I have a whole separate lecture on the health risks associated with this disorder. We can see that ADHD is a very persistent disorder, even if that isn't documented by the child-focused criteria I mentioned in the DSM. That people with ADHD can outgrow the DSM, even though they may not be outgrowing their symptoms relative to other people of the same age and sex. And we can hazard a guess that about 65 to over 86% of children diagnosed with ADHD will have some degree of ADHD that impairs them in adulthood upon reaching adulthood. Thus, we see that ADHD is a very impairing disorder, more impairing than most disorders we treat in outpatient psychiatric disorders. But the hope for people with ADHD is the following. ADHD is among the most treatable of psychiatric disorders. What do I mean by that? We have more treatments that produce more improvement for more people who have the disorder than we see in other psychiatric disorders. For instance, let's look at anti-anxiety drugs. Anti-anxiety drugs are only about 1/3 the effectiveness in managing anxiety that ADHD drugs offer for managing ADHD and for more people with ADHD. So our greatest problem right now isn't that we don't have good treatments for child and adult ADHD. It's that people are not able to avail themselves of these treatments. Some of them may not be available in the area. Services to diagnose ADHD may not be available in that region. So there's under-identification, under-diagnosis of ADHD, and therefore under-treatment of all of its risks, including its health risks. So, given how well and how responsive ADHD is to treatment, our job is to try to remove obstacles to these people getting appropriate diagnostic services and treatments available for them to reduce the myriad of risks that I've shown you in this presentation. Thank you so much for joining me for this lecture. I hope that you found it informative, and I hope that you will register for other lectures of mine in the future. Thank you, and be well.